So what I wanted to emphasize in this case is, this is an older woman who present with usually the symptoms of pancytopenia. Mucocutaneous bleeding is very common in aplastic anemia. Although platelet counts are low in this disease, it's very rare for us to see major bleeding like CNS hemorrhage or gastrointestinal hemorrhage. So usually they present with mucocutaneous bleeding, and she had anemia, so she had a pre-syncopal episode. And patients usually look okay, except from some paleness. They usually look fine. They don't have any stigmata of a chronic illness. They don't lose weight. They don't look ill. They don't have other findings except for the ones associated to the low blood counts. So this is not unusual for us to see in terms of the presentation. So patients with aplastic anemia should not have organomegaly. If they do, you should think of an alternative diagnosis, and they should not have lymphadenopathy either. So unless, the only exception would be if there's an infection that would justify the swollen lymph nodes or the enlargement of the spleen or liver, but that's very unusual. So if you palpate an enlarged node or a group of nodes, or if you find a spleen, you should really think of an alternative diagnosis for that patient. Usually they present with what you would see with patients who have low platelets with petechia and bleeding and obviously pale. So you should know one before. So obviously the bone marrow is done. She was pancytopenic. She had a very low hemoglobin, very low white count, and a low neutrophil count, and a low retic count. So this is basically all three lineages are down, and a low platelet count. She had a normal karyotype. It can be sometimes difficult to differentiate in some patients, a patient like her, from having hypoplastic MDS. We usually look at some of the non-erythrocytic lineages to see if there's any mononuclear megakaryocytes or some other dysplasia in the myeloid precursors. You can see sometimes mega erythroblastic changes, and that can just be aplastic anemia, especially if there's a PNH clone. So that can be something that can actually add some confusion to the diagnosis. Karyotype, obviously, if they come back abnormal, it can help depending on what the abnormality is, but keep in mind that there are several reports showing that patients just like this with a hypocellular marrow and a deletion 13q don't have MDS. They just behave as an aplastic anemia patient and get, respond just as well to ATG cyclosporin or some form of immunosuppression. So in some cases, when there's more dysplasia or more cytogenetic abnormalities that might associate to the dysplastic findings, you might have a situation of a hypoplastic MDS. But these patients actually also, as Dr. List mentioned, could also respond to immunosuppressive therapy, some of these MDS patients. So she did receive horse ATG cyclosporin, and it's not unusual for patients at 6 months is usually the time period where you assess for a response. You assess for 3 and 6 months, and if they don't respond at 6 months, you consider them a non-responder or a responder. In this case, she had an improvement in her neutrophil count and the retic count, but not sufficient to be considered a responder based on committed criteria, which is usually what's used in protocols for severe aplastic anemia, which is a retic count less than 60, neutrophils less than 500, and a platelet count less than 20,000. So after 6 months, she got these counts, which are somewhat improved if you go to the next click. And although she still remained transfusion dependent for red cells occasionally and platelets more often. So she obviously required more therapy. She didn't infect, but she had a cyclosporin intolerance, a mild one, with a creatinine of 2. So these are the options that we actually presented. Okay, so more immunosuppression is something that would be considered, although she was intolerant of cyclosporin, and you may not want to give cyclosporin monotherapy or in combination with ATG for that matter. And most of the trials which looked at second rounds of immunosuppression were with ATG and cyclosporin. Alemtuzumab has been tested without cyclosporin. There's an abstract at this meeting from Brazil, retrospective in alemtuzumab. We did treat over 100 patients prospectively with alemtuzumab without cyclosporin, but it is more immunosuppressive, and she has adequate neutrophil counts, so you have time in this patient, and she didn't have any infection. Transplantation would obviously be not something we would consider, especially with an adequate neutrophil count. She's not getting infected, and the main risk of these patients is infections. So she's just the issue of transfusion. So we had the option of actually at the time in putting her on a trial, and she actually did enroll in the Eltrombopag trial, and she actually improved. Her platelet count went over 50,000, her hemoglobin went to 11, and she went off transfusions and did very, very well with a very well tolerated. The one thing that was done afterwards, after a robust response in terms of her counts, she was later on discontinued of eltrombopag. Romiplastin is something that has been only recently reported in trials. It's been reported at ASH in abstract form, but only recently in a full format form. And it actually appears to be active, so it's still earlier in its development, but it appears to be a class effect in terms of activity in this disease, but we have to learn more from romiplastin in order to come to that conclusion in terms of the right dosing, duration, et cetera, and which patient. So this is what I wanted to basically discuss. Now, just to finalize, if this was a younger patient, 22, you might want to consider transplantation options, especially if she didn't have identification of a HLA-matched sibling donor at diagnosis, or you had time to put her in a registry and find a 10 out of 10 unrelated donor. You might want to consider in younger patients consolidate, or at least go for a more definitive approach with an unrelated bone marrow transplantation for younger patients. Obviously, if you're 62, the enthusiasm is much lower to do that. Mortality really goes up for transplantation, both related and unrelated, over the age of 40, and that has not improved with time. If you look at the ABMT, Bacigalupo's data, over 40, you still have increased mortality. 40 to 50% of patients die in the first year or two after transplantation if you're older. So age is still a very potent and important risk factor for this treatment modality in aplastic anemia. So these are the main considerations I want to make in this case.
The next case is much more interesting. So a 64-year-old woman previously treated for breast cancer with lumpectomy followed by dose-dense doxorubicin, cyclophosphamide, and Taxol and radiation presents to your clinic with pancytopenia. Physical examination is notable for pale conjunctivae and scattered petechiae. A complete blood count with manual differential shows pancytopenia, but without the presence of circulating blasts. You arrange for a bone marrow aspiration and biopsy to be done immediately. The aspirate smear shows 12% myeloblasts and multilineage dysplasia. Cytogenetics are complex, and a TP53 mutation is present. What drug is being investigated for treating patients with TP53 mutant myelodysplastic syndromes? Okay, so pretty good. So correct, APR-246 is the reactivator of P53 that's being investigated in this setting. Decitabine is not being investigated. It's a drug that you could potentially get, and some people in my practice have taken to giving 10 days of decitabine to P53 mutant patients, despite no good survival data. Ivosidenib and enasidenib are IDH1 and IDH2 inhibitors and would have no role in the treatment of this patient. Okay, so this is really interesting. So this is actually, we're all going to play for those of you who are doctors, you're going to be doctors, and for those of you who are not MDs, you get to play doctor today. This is a real patient of mine who this happened to the day before ASH. I told him I was going to ASH, and he said, can you please talk to your colleagues about what we're going to do? So I thought, what better situation than having a group of 300 people in a room and to talk about what we're going to do. So this is a real patient. 60-year-old man, he's a lawyer in New York City. He was diagnosed with FLT3 mutant AML with a FLT3 ITD. He achieved an MRD negative complete remission with 1 cycle of 7 and 3 midostaurin and proceeded to have an allogeneic bone marrow transplant. 150 days post-transplant, the patient relapses. I started him on single-agent gilteritinib, and he achieved an MRD positive complete remission. He then subsequently got DLI, and gilteritinib was continued. He then is in an MRD positive complete remission, but basically normal blood counts, not transfusion dependent, not admitted to the hospital, just has a little bit of MRD for approximately 1 year. 1 day before the 2019 ASH annual meeting, his local physician calls you, me, to report the presence of 30% myeloblasts in the patient's peripheral blood. What is the next best step? A, treat immediately with reinduction chemotherapy such as FLAG-IDA. B, enasidenib. C, test for molecular genetic abnormalities and wait for the results before treating. Or D, midostaurin as a single agent. Okay, we've got treat immediately, test for molecular genetic abnormalities and wait, and midostaurin as a single agent. So in discussing this, I'll tell you what I'm going to do, what I thought I would do, and tell you what I thought I wouldn't do. So I would not give midostaurin as a single agent because the efficacy of midostaurin as a single agent in relapsed and refractory disease is minimal. There is actually no activity in that setting. So I certainly would not do that. I've been toying with the idea of giving him immediate reinduction chemotherapy, but what I want to know is, I want to know before I start anything, what is driving this relapse? And we know that in patients with FLT3 positive disease who are on gilteritinib, there are really three mechanisms of relapse. One is that you can get a new FLT3 mutation, an F691L gatekeeper mutation, where the gilteritinib can't bind into its binding pocket, and there's some data that suggests if you increase the dose of gilteritinib to 200 milligrams daily, you might be able to overcome that, so that potentially be an option. There are some patients who actually relapse with IDH1 or IDH2 mutations, so if he had those mutations, I might give him single agent ivosidenib or enasidenib. There are two patients in the series who actually relapsed with a BCR-ABL translocation. So they developed CML as their resistance mechanism to FLT3 inhibitor. This is a paper in Cancer Discovery, I think published by Kathy Smith. And then the last group of patients develops RAS mutation. So what I typically do in this situation is I wait for the molecular genetic results to come back, and then I make a decision if I'm going to continue with the small molecule inhibitor or if I'm going to give the patient reinduction chemotherapy, which unfortunately in this case I'm concerned isn't going to work very well.
Presents with a symptomatic anemia, hemoglobin of 7.5. Bone marrow is done, which is hypercellular dyserythropoiesis, oligonuclear megakaryocytes, and the cytogenetics reveal isolated deletion of 5q in 14 of the metaphases. The NGS panel shows a DNMT3A mutation with a VAF of 16%, a TET2 mutation at 24%. Her serum erythropoietin levels were inappropriately low, so she was started on ESA and responded, but it was not sustained after about 4 months. At that point, she was started on lenalidomide. And she did well, achieved transfusion independence, complete cytogenetic response, but after 15 months, had recurrence of the anemia as well as transfusions. So bone marrow was repeated. There's no increase in blasts. So the question is, which of the following statements are false? Number one, acquisition of TP53 mutation confers resistance to lenalidomide. Number two, preliminary data shows dexamethasone with lenalidomide may overcome lenalidomide resistance. Number three, a bone marrow transplant consultation is reasonable. And number four, a trial of luspatercept and lenalidomide refractory MDS. A little bit of everything. And I don't know that any of these are false, to be honest. I mean, luspatercept could be interesting in lenalidomide refractory MDS. We just don't have any data. They've been excluded from them all. But I think the acquisition of a TP53 mutation, this is a real issue in del5q. 20% of people at the outset of diagnosis will have a TP53 mutation. And why it's specifically associated with del5q as opposed to any other isolated cytogenetic abnormality other than complex karyotypes is completely unclear. And they do have a lower probability of response to lenalidomide. Dexamethasone, apparently no one was listening. It shouldn't be 8%. But you can salvage patients, as I showed you earlier. I think a bone marrow transplant consultation actually is reasonable, even if you salvage somebody. The median survival, at least in our data combined with the French, is around 15 to 18 months. So it probably is that these are patients that their disease is actually changing, and exploring a transplant, if they're of appropriate age and comorbidities, is reasonable. And we just, as I mentioned, we don't have any data on luspatercept in this situation. Yeah, please do.
What about adding EPO to the Revlimid?
Yeah, and I think it actually, I wouldn't do it in the absence of dexamethasone. And the reason I say that is this. I mean, we'll present the ECOG trial in non-del5q, where lenalidomide has two effects. One is synthetically lethal for del5q clones. The other effect that it has in non-del5q erythroid precursors, it stimulates the generation of lipid rafts that contain JAK2 signaling competent complexes. So it actually enhances sensitivity to erythropoietin. And that's the result of the ECOG trial that will be shown on Monday, showing it's actually very effective. And the addition of lenalidomide with addition of dex to lenalidomide, these people who have failed in del5q, does not suppress the clone. It actually helps to expand it and differentiate. So it might be worthwhile. I just don't know of any data. It's an interesting thought.
This is Mr. Z, who is a 69-year-old male with a past medical history significant for hypertension, hyperlipidemia. coronary artery disease and rheumatoid arthritis, who was recently found to have mild normocytic normochromic anemia during his annual physical exam. And this is his basic workup, which showed mild anemia with normal MCV, slightly elevated RDW. The B12 and folate were done, and they were within normal range. And you also have iron studies, which showed low normal iron with low normal TIBC and elevated ferritin. So peripheral blood NGS leukemia MDS panel was done, of course, and showed DNMT3A hotspot mutation at VAF of 8%. The patient was referred to hematology clinic for presumptive diagnosis of MDS. Bone marrow biopsy revealed appropriate cellularity for age, no significant dysplasia, and normal karyotype. So the most likely diagnosis is A, CHIP, B, CCUS, which stands for clonal cytopenias of unknown significance, MDS, anemia unrelated to clonal process, and A and D. So I think the right answer is E, A and D. The reason why I'm saying that, if you look at the studies, there is probably an explanation for patient's anemia. So the patient has a history of rheumatoid arthritis, which is inflammatory condition, and his iron studies and hemograms are consistent with what we know as anemia of chronic inflammation. The one caveat that I actually want to stress here is that you have to interpret the NGS panel with caution. It's not meant to be a diagnostic shortcut. It's a good adjunct test in a certain population of patients, but it's not pathognomonic for MDS or aplastic anemia. And with the VAF of 8%, which suggests that you have only 16% of clonal cells, it's really hard to explain anemia by minority of cells being mutated, while most of the hematopoiesis is coming from the normal marrow. So likely in this case, the patient has two processes going on. One is CHIP, and the second is anemia unrelated to clonal process, which is likely anemia of chronic inflammation. So he truly values your opinion and professionalism and decided to see you in clinic on a regular basis. So you're obviously ecstatic about it. And you propose the following master plan. So A, you want to repeat the bone marrow evaluation and NGS panel to monitor the changes in VAF every 6 months to 12 months. You want to discuss the importance of modifying cardiovascular disease risk factors and explain to the patient that the risk of hematological malignancy is very small. You repeat complete blood count with differential every 6 months. B and C, all of the above. Okay, perfect. That was really good. So yes, I think the correct answer is B and C for the following reason. I think we don't really recommend repeating bone marrow biopsies or monitor NGS or monitor clone using NGS panel because we really have nothing to offer if the patient has no cytopenias. Well, that changes if the patient develops cytopenias that are unexplained. I think you want to make sure that there is no progression to clinically obvious MDS or other hematological malignancies. Of course, you discuss the importance of modifying cardiovascular risk factors, so that's a good answer. And the repeat complete blood counts with differential every 6 to 12 months or every 6 months. I think that's probably the right answer. We don't know. Some expert would recommend doing that. And I would personally recommend having CBC done with annual physical exams just to make sure there is no progression of cytopenias or development of cytopenias.
Okay, so this is a 55-year-old woman with post-PV myelofibrosis who's been managed without treatment for 2 years. She just progressed to myelofibrosis 2 years ago. She has an enlarged spleen, but now what's new is that she's complaining of severe fatigue, night sweats, and weight loss. And in terms of her labs, she has mild anemia. She still has some thrombocytosis, a little bit of leukocytosis, but she doesn't have any blasts in her peripheral blood. She has a bone marrow biopsy that shows grade 2 fibrosis. She has normal cytogenetics, and she's JAK2 mutated and TET2 mutated, but doesn't have any other high-risk mutations. So what is her DIPS plus score? Okay, good. So her DIPS plus score is 2. She gets the 2 points for having her hemoglobin below 10, but she doesn't have any other, that'll give her two points, but doesn't have any other, like the age, the high white blood cell count, that will give her any other points towards her DIPS. So what are her treatment options? Transplant, a JAK inhibitor, or anything, any of the above? Okay, so most people said any of the above, and the reason why I put this question is just to highlight that there's not necessarily a real answer or one answer for each myelofibrosis patient, in particular people who have features that would make their disease more high risk. And so it's really based on the person's personal preference, what their goals of care are. For this woman, she's relatively young at age 55, and she's starting to be symptomatic from her myelofibrosis. Although in terms of her cytogenetics or her mutational profile doesn't necessarily have clues that she's progressing to an acute leukemia very quickly. So a transplant is a serious discussion that should be had for the patient, potentially not necessarily right now, but potentially sometime in the future, given that she's had her disease for quite a while, and she may progress. It is important to time the transplant appropriately for patients with myelofibrosis. I'd really like to transplant them before they develop an AML. In this patient, because she had splenomegaly, if transplant was in her desired future, that probably reducing her spleen size with a JAK inhibitor would be in her best interest prior to transplantation. And this woman didn't necessarily have significant anemia, but unfortunately that's a major issue for a lot of myelofibrosis patients, for which we don't necessarily have great interventions for.
So at the end of the session, I thought it's only time for 3 very simple questions. The first is a 57-year-old gentleman with high-risk MDS is coming to your outpatient for counseling about whether he should undergo allotransplantation at the time of diagnosis of high risk. So he's asking about the greatest challenges and risk of transplantation, still has. What would you say, what are the greatest risks? Is it non-relapse mortality? Is it CMV? Is it graft versus host disease? Is it donor search, or is it relapse? Thank you very much for listening to my presentation. And actually the same patient is, you're now counseling the patient for doing a transplant or no transplant. He's asking about evidence that allotransplant is advantageous compared to azacitidine alone. So that he questions whether he should undergo AZA only, whether this is maybe less effective than transplantation. What would you answer here? Thank you again for carefully listening to my presentation. And the last question is, 52-year-old woman with complex karyotype AML achieves a CR after 2 cycles of induction. MRD testing by flow still reveals a positive residual leukemia phenotype. Is MRD important at this time of the analysis for the outcome after transplantation? Answer A, what is MRD? Okay, so if somebody does this, of course. No impact, high impact. Okay, so actually the 8% of the people voting for number 1, please get up. Okay, thank you. Sit down, please, thank you. Okay, so thanks for listening.